Bismillah ar-Rahman ar-Rahim. So again, today we'll be talking about few topics that we see often as a pediatric urologist, mainly an approach to antenatal hydronephrosis that take us to different topics, including posterior urethral valve, ureteropelvic junction obstruction, vesicoureteral reflux, and duplex anomalies. Also, this can take us also to neurogenic bladder approach, and we'll try to cover as much as we can and make it simple for you guys. So to start, our objective today is to identify the common causes of antenatal hydronephrosis and also to be able to assess and manage different causes of antenatal hydronephrosis. Now, with the advance of technology and the great use of ultrasound to help to diagnose issues early in pregnancy, ladies have more chance to know about anomalies early on and get intervention for their babies early on to help to protect their organs. So this slide is just showing you some epidemiology. Antenatal hydronephrosis is one of the commonest antenatal diagnoses that our colleagues in obstetrics sees and sometimes send their patients to us for counseling. It represents 50% of all prenatal anomalies, and to me this is a very large number. So basically it's overtake all the remaining systems. And the persistence of these conditions on the postnatal period in 50% of the time. And when we look for the causes, as I mentioned earlier, we divide it as is it unilateral or bilateral? Is it a boy or girl? And depending on that, we decide what's the differential diagnosis and what's the commonest in that group. So there is a grading system used to grade hydronephrosis, and I don't think you guys will be seeing this often, but sometime you'll be the one who is referring those patients to us. So this system is basically a system utilized internationally to help surgeons or urologists to speak the same language. So if I say this patient has grade 4, everyone knows what's grade 4, so I don't need to explain it. And just to go over it, in this slide, I just show you the 4 grades of hydronephrosis. We see just dilation in the renal pelvis, the extrarenal part, this is a grade 1. If we see more of intrarenal dilation, this is a grade 2. If you see more of a calyx dilation, it's a grade 3. If you see severe dilation with thinning of the parenchyma, this is grade 4. And this is just to make everyone familiar with, even if I don't see the ultrasound pictures and I tell you if this patient had grade 4 hydro, you know he has severe hydronephrosis and thinning of the parenchyma. So when we look at the antenatal ultrasound, if you have an unexpert radiologist, they might call this ultrasound picture hydronephrosis. And actually this is how the normal antenatal kidney looks, because the kidney forms of multiple lobules that joins together as circles form the kidney. So we call this appearance fetal lobulation. But if we see this picture on an antenatal ultrasound, this shows you a clear hydronephrosis. And if you have an expert obstetrician, he will call this as hydronephrosis if they see it. So when we assess those patients, first we have to take some history, and in the history we assess the maternal history, which mainly the pregnancy itself and the previous pregnancies. So we ask if there is a history of diabetes, hypertension, as some of these conditions can be associated with older age or even some medical conditions. We ask about if there is any family history of GI anomalies, any history of previous pregnancy with any other anomalies or syndromes, any medications of the pregnancy. If this family had any child with previous antenatal hydro, what was the diagnosis postnatally? Was it reflux or ureteropelvic junction obstruction or any other anomalies? And also we have to know if we see them in antenatal period, if this is a boy or girl, because the diagnosis can be different between boys and girls. And whenever that baby is born, if they call us for the consultation, we have to ask if this baby is voiding or not, because we have to think of something that there is some obstruction in the urethra, like in posterior urethral valve. And we look at the antenatal ultrasound. This is a boy or girl. Is this a single or multiple pregnancy? How is the amniotic fluid amount? And why do we care here? Because what happens that starting from 18 weeks, going all the way to 22 weeks, the baby kidney will start producing urine. When that happens, in the first 18 weeks to 20 weeks of pregnancy, the amniotic fluid is formed by the placenta exudate. Whenever that baby starts producing urine, the amniotic fluid will be produced by the baby urine. So the baby will be voiding the urine and drinking it, and that will make the cycle of the amniotic fluid inside the baby. So if there is any form of obstruction like posterior urethral valve or urethral atresia, those babies will have oligohydramnia, severe oligohydramnia, or even anhydramnia, because there will be no fluid around the baby, and that can affect the growth of the baby. So that's why we care as a urologist if we see this patient as antenatal consultation. If this is a boy and there is severe oligo and there is bilateral hydro, we think of there is a diagnosis of posterior urethral valve or urethral atresia. Then we assess, was the hydro seen in the pregnancy in one side or both sides? Have they seen the bladder at all during any of the scans? Because if you have bladder extravy, for example, they might not see the bladder full at all. And also we We asked our colleagues in obstetrics, have they seen any other anomalies? Because we think of syndromes, like Vactor syndrome can have some renal anomalies. And have they seen the urethra dilated? Because there's something we call the keyhole sign, and I'll show it to you in the next slide, which is basically diagnostic for high likely or high chance of posterior urethral valve in a baby with bilateral hydro. And how is the growth of the baby if there is IUGR or something like that? So we talked about the antenatal hydro and oligohydramnia, and why do we care about the amniotic fluid? And this is a key piece that our colleagues in obstetrics use to help to diagnose this condition antenatally, specifically posterior urethral valve, because in some conditions they have to intervene early in the pregnancy. So just before we move on to the specific diseases, just talking about some anatomy. So if we have someone with bilateral hydronephrosis, especially in a boy, we think of something distal, which specifically can be posterior urethral valve, anterior urethral valve, urethral atresia, or bladder anomaly like spina bifida with neurogenic bladder that's causing high pressure in the bladder, which can cause bilateral reflux. So if we see bilateral hydro, we think of something distal, even though you can have, for example, reflux on both sides with no distal anomalies. You can have bilateral ureteropelvic junction obstruction, bilateral uretrovesical junction obstruction, but common is common. If you have bilateral, you have to rule out something distal. So that's why when the workup, you'll see when you have bilateral hydro in a boy, you have to do voiding cystogram to rule out posterior urethral valve, because if we miss that diagnosis, this patient can have major consequences. Looking at the investigations that we do postnatally, first we have to repeat the ultrasound to make sure that what we see antenatally still persists. Then whenever that result is out, we decide if we need to do further testing. So the three tests that we use often is ultrasound, voiding cystourethrogram, and nuclear scan, which is called MAG3 or DMSA, and I will show you that in the next few slides. Intravenous pyelogram is a test that we use. We used to use in the old days, but we don't do it. We don't use it anymore because it uses nephrotoxic material, and also there is too much radiation. The nuclear scan gives us the same answer that we get from the intravenous pyelogram, and we don't do it anymore. So ultrasound, you have to be familiar with how the ultrasound looks, because the majority of the time you will be the one reading it, especially if it was done in the bedside, or even you don't need to wait for the report, because with time you get used to it, especially for us as a pediatric urologist. So in this scan, we can see this is the right kidney, this is the liver, no hydro, there is good corticomedullary differentiation. On the other side, the same thing, cortex medulla, no hydro, no ureteric dilation around in the area of the renal pelvis. And this is the bladder. As you can see, it's nice and smooth, with no echoes inside it, no ureteroceles, no dilated ureters behind it, so it looks like normal. This is how normal scan look. I'll just show you how the normal scans look, so when we see cases, we know the difference. So voiding cystourethrogram is a common test that we do, and it helps us to make two diagnoses, mainly the presence of vesicoureteral reflux, and also assess the size of the bladder and the urethra if there is any obstruction in the urethra. So we always have to do a scout film to assess for any soft tissue or bony anomalies, because you can pick spina bifida from this image if there is a clear spina bifida. So we put a catheter in the urethra, fill the bladder. The name of this test tells you what's done in it. So we want to do voiding cystourethrogram. That's mean I have to fill the bladder, take out the catheter, take a picture for the baby or even the patient voiding. So we have to do a voiding phase. If we don't do voiding phase, this is what we call cystogram, and it's just used if there is a pelvic fracture and you want to make sure there is no bladder extravasation or a bladder rupture. But if you want to assess the urethra or even reflux, you might not see it till the baby contracts his bladder. So you'll see the urethra in the next slide. So you can see here the urethra is seen nice and smooth. Bladder looks very regular here. There is no reflux, because at the end of the ureter there is a valve that makes the urine goes from the kidney down to the bladder, not the other way. So this is the second modality. Third modality is a diuretic renal scan, which is basically they put an IV and inject radioactive material that's specific for the kidney that gets absorbed and excreted by the kidney. And to make this process quicker, they give Lasix, so to make the excretion quicker, so they don't need to wait for a long time to see the result if there is an obstruction. So this test called MAG3, and that's the name of the material that's used. And there is another material used called DTPA, and these are functional studies, basically telling you there is uptake by the kidney. That's mean the kidney is functioning. Second, it also takes in consideration the excretion phase. So as you can see later in the study, we start seeing the material getting to the bladder, and at the end of the study, both kidney drain. So it tells you if there is obstruction in the pelvis, ureter, or even if the bladder is emptying or not. The third modality of the nuclear scan is called DMSA, which is basically a static image where you get similar to this picture only. And this tells you if there is uptake by the kidney or not. So it only tells you function. It's a it's static image. There is no functional or excretion phase. And we used to do that to assess if there is a poor functioning kidney, small kidney in the ultrasound, or even if you have someone with recurrent febrile UTI and you want to assess if there is scarring in the kidney from the recurrent febrile urinary tract infections. But for obstruction assessment, we always have to do DTPA or MAG3 or diuretic renal scan. This scan, as you can see here, both kidney drained. It also give you curves, so there is uptake. Whenever they give the Lasix, both kidney drained completely. So postnatally, we have to make sure the baby is voiding. How is the baby creatinine? And usually we don't judge by the first 24 or 48 hours creatinine because it represents the mother or the maternal creatinine. We still do it to make sure that we're watching the trend going down. But if you do a baby creatinine the first day of life and it's 100, this is very high for a baby. Usually it's 30 to 40 for a baby. And if you do it on day 3, it will represent his own creatinine. We start them in antibiotic prophylaxis because we still don't know what we're dealing with till we do the testing and decide if this patient needs prophylaxis or not. We always have to repeat the ultrasound postnatally, and whenever we see it, we decide if we're doing avoiding cystogram, nuclear scan, or even just follow-up ultrasound in a month or 2. So we'll start with the cases here, and basically here we'll be talking more about specific disease. So we start with the first case. Ideally, this presentation is interactive, but for the sake of the time, I will just go moving from one condition to another. We'll leave time for questions at the end. So this is a 2-day-old boy, spontaneous vaginal delivery, found to have bilateral hydronephrosis on an antenatal ultrasound. We did postnatal ultrasound, and this is his postnatal ultrasound. This is right kidney and left kidney, and you can see there is bilateral hydronephrosis. Going back to the grading, this is a grade 4 because you see there is thinning of the parenchyma. This is grade 3 because there is a calyceal dilation, pelvis dilation with no thinning of the parenchyma. And the fact we're seeing bilateral hydro in a boy, we always have to keep in our mind posterior urethral valve. We can see here in the bladder wall is very thick, and this is supporting the idea there is somehow distal obstruction. So thickness of the wall of the bladder that goes with a neurogenic bladder, and if this patient has a posterior valve, in fact there is obstruction, the bladder is struggling to void, and with time the muscle grows more because every time it's like pushing hard during the pregnancy and even postnatally, and that makes the bladder wall very thick. We see this picture, most likely this patient will have posterior valve, but we have to do voiding cystogram next. This is what I told you earlier. This is an antenatal ultrasound for the same patient, showing what we call the keyhole sign, which is basically this is the bladder, this is the posterior urethra dilated, and this is diagnostic or pathognomic for posterior valve. So they called it keyhole sign because it looked like the old keys where you have the circle on the top and the bottom is straight, and this is like the old keys opening. This is the same patient posterior valve, which is showing you the same picture of dilated posterior urethra, and this is where the valve is. And if we continue the images, the bladder looked very irregular, which is going with the neurogenic bladder, dilated posterior urethra, and always there is a bilateral vesicoureteral reflux. As you can see, contrast is getting up to the kidney, and also here you can see contrast in the kidney. So now with this picture, we have a diagnosis of posterior urethral valve. In this condition, it happens in 1 in 8,000 to 25,000 live male birth. It doesn't happen in girls, of course. The congenital obstructive membrane. And when we go with a cystoscope, this is the membrane obstructing the urethra. So if this is the lumen, this is a crescent-shaped membrane, and this is the remaining urethra is open. And just that helps you to know when we treat it, we go with a cystoscope. We ablate the valve by incising the valve at 12 o'clock, 5 o'clock, and 7 o'clock, and we disrupt that membrane. So the first step of management, whenever that baby is born, if he has bilateral hydro, till we do the voiding cystogram, we ask our colleagues and neonatologists to place a feeding tube to drain his bladder, and we usually don't use fully catheter, we use feeding tube in that condition. And usually it's easy insertion. People always get alarmed and call us to place the catheter, and it always goes in. That valve, it works like a one-way valve, so things can go in but cannot go out well. Then those babies will need NICU support because they can have severe pulmonary hyperplasia from the post-surfactant production, and that's very common in babies with oligohydramnios secondary to posterior valve. So this patient will need they need to be born in a tertiary hospital where you have a neonatologist, nephrologist, and pediatric urologist. Whenever that baby is stable, we always do daily creatinine. Whenever that baby is stable, we do our procedure during the same admission before discharge. We always put those patients on antibiotic prophylaxis because they have bilateral vesicureteral reflux. So the definitive treatment here is cystoscopy and valve ablation. If you have a premature baby, which usually the weight is less than 2.8, we usually in that condition try to do cystoscopy, but the resectoscope we have is 9 French. It might not fit in the urethra, and in that condition we do vesicostomy, which is basically similar to what you guys do when you do colostomy. You would make a small incision, 2 finger above the symphysis pubis, going through the abdomen, going through the fascia, delivering the dome of the bladder to the skin, and that helps to reduce the pressure till the baby grows more. And in that condition, if we end up doing vesicostomy, we always wait for 6 months to 1 year at least to give their bladder and kidney a rest. And later on, we'll do the valve ablation and closure of vesicostomy. Just to mention here before we move on, posterior valve is not just a disease you treat one time and the patient disappears. This is a wide spectrum disease. That means you might see a patient with renal failure from the beginning, or they might die in utero because they might have hydronephrosis, or you might have a patient that you only do the valve ablation and follow them regularly without intervention. You might have those patients in the middle who has neurogenic bladder secondary, that bladder developed in high pressure, and they may need to use anticholinergic medication, do intermittent catheterization. And when we talk about neurogenic bladder, we'll touch base more about valve bladder syndrome, because valve bladder syndrome is basically that even if whatever you do to drain that system is messed up because it developed in high pressure and they cannot empty properly, and you have to use some support, and you might need to do bladder augmentation and catheterization on a regular basis. So treating the valve is not the end of the road, and a good number of these patients, I would say 20%, will need transplant because those kidneys develop in high pressure and will not work properly. So we work very closely with our colleagues in pediatric nephrology to treat those conditions and those babies, and some have hard time postnatal. Second case, which will be straightforward, 5 days old boy with unilateral hydronephrosis, diagnosed in antenatal ultrasound. This is postnatal ultrasound, and we can see here on the right side there is a grade 3 hydronephrosis. The dilation mainly in the kidney with no ureteric dilation, no ureteric dilation behind the bladder on the right side. Left kidney looks normal, bladder looks normal. In that condition, the fact I'm not seeing ureteric dilation, first thing comes in my mind, can be something higher at the ureteropelvic junction. If I see ureteric dilation all the way down, then I would think of, is it reflux? If we think of this picture again, it could be obstruction here, or vesicureteral reflux. So these are the 3 conditions that comes in my mind. And the fact I'm not seeing ureteric dilation, at least I'm thinking this might be something there. So when I discuss with the patient the causes of hydronephrosis, so we divide this into obstructive, refluxing, or antenatal hydronephrosis of pregnancy, which gets better with time. So what we do in the workup is we're trying to exclude this condition, and if we exclude reflux or obstruction, we just follow them regularly with ultrasound, and we call this hydronephrosis of pregnancy that gets better with time. Going back to our case, so as we can see, there is a dilation mainly in the kidney. So in that study, we did nuclear scan, and we can see there is uptake by both kidney, and in this scan, this is the right and this is the left kidney. And our hydro on the right side, we can see the right kidney looks hydronephrotic in comparison to the left. So this is 1 minute, 2 minutes, 11 minutes, 21 minutes, and we wait till the end of the study. And you can see at the end of the study, the left kidney excreted completely. And the right kidney, we can see the holdup at the ureteropelvic junction. We see this black material goes all the way down, then we think of something distal, either reflux or uretrovesical junction obstruction. If the obstruction is here, or if we want to rule out is it reflux or obstruction, we leave a catheter in the bladder. So why would we have hold up here if there is reflux? Because the urine will be going upward, the axial urine will be jamming forward. In this condition, we drain the bladder with a catheter, and if we see the hold up here, then this is diagnostic of uretrovesical junction. Going back to the curve, as you can see here on the left side, there is uptake. Whenever they gave the Lasix, it drained completely. On the right side, there is uptake. Whenever they gave the Lasix, plateau and never drained. And the T-half here is infinity. That means that kidney never drained at the end of the study. And that's diagnostic for ureteropelvic junction obstruction. It's the most common cause of unilateral hydro in fetal kidneys, more common in males, or more common in the left than the right. Nobody knows why. And this is how it looks. And if we look at this ultrasound, exactly it's what we see in this picture. This is the narrowing here. The narrowing here, usually, it's the narrowing in the lumen, but you can have a polyp inside, or you can have a crossing vessel also causing the narrowing. And that's something we treat surgically to fix. So no need for urgent intervention. That means you don't need to do the surgery just postnatally. We usually wait for at least 4 to 8 weeks of age. Indication to treat if this patient is symptomatic or reduce function, or also for compliance to follow up. What we do in this procedure is what we call pyeloplasty, which means fixing the narrowing in the renal pelvis. So basically we cut this piece and we connect things back together. This is how it looks. It sounds easy, but it's more than that. And usually in my practice, I do this laparoscopically or robotically, and it works very well with great results. Other options, these are more advanced options. Ureteroceles, usually it's done if you have done pyeloplasty multiple times and fails. We make a partial nephrectomy, like removing this part of the parenchyma and connect the ureter to the calyx on this side. We rarely do this procedure. And if you have a patient who had the pyeloplasty and that failed, you have an option of going in with a ureteroscope and dilating that area. We call this endopylotomy, and it can be done with a balloon or with a laser. Nephrectomy is an option if you have a non-functioning or poor functioning kidney. And if this patient comes in sick or septic, you have to put a nephrostomy tube till he's better, or you can leave a double J stent and you come back later to fix the narrowing with a pyeloplasty. Outcomes of surgery, looking at the outcomes of different approach, as you can see, 97, 97, 96, and this is comparing to open to robotic and lab. Third anomaly that we deal with is vesicoureteral reflux. So this is a 5-day-old girl who was diagnosed with bilateral hydronephrosis, and I use this always as a trick question. When I tell them what's the differential diagnosis, the first thing they would say is posterior urethral valve, and this does not happen in girls. So this patient had bilateral hydronephrosis. As we can see, this is the left kidney, grade 3 hydro, and the right, grade 3 hydro. As you can see, there is no thinning of the parenchyma, and the fact we're seeing the calyx dilated and the renal pelvis dilated, that's why it's grade 3. We see the ultrasound of the bladder here showing no thick wall bladder, and you can see ureters dilated all the way down. Seeing this picture take us back to the previous discussion, is this is uretero-vesicular junction obstruction, or this is vesicoureteral reflux. And there's a third differential diagnosis here, which we call megaureter. Megaureter is basically saying that the ureter is more than 7 millimeter in size. And that can be refluxive megaureter, obstructive megaureter, or even megaureter that's called non-obstructed, non-reflux. And this will be advanced for the, I wouldn't get into more details because megaureter is a very controversial topic, and basically take us back. If there is reflux, we have to treat it as a reflux, even if it's a megaureter, and if it's obstructed, we have to treat it as obstruction. So voiding cystogram was done for this girl, and as you can see here, there is reflux in both sides, and there is a grading system for reflux. The bladder wall looks regular here, so we don't think of neurogenic bladder, and the reflux happened during filling, even before the girls start voiding. But if we don't see reflux here, we have to ask the radiologist that they have to wait for the baby to void, because if sometimes reflux doesn't show till the baby void and contract his bladder. So if you don't see reflux when you have passive filling of the bladder, that doesn't mean this patient does not have reflux, and you have to do voiding first. So grading system for reflux. This is the system, the same thing we use for ultrasound, hydronephrosis classification. It helps us to unify the literature, and also when we discuss cases and when we discuss treatment options. So grade 1 is basically reflux in the ureter. Grade 2 is in the ureter all the way to the pelvis. Grade 3 all the way to the pelvis, and we can see the calyx of the kidney. Grade 4, there is mild tortuosity of the ureter with mild blunting of the calyx. 5 is basically very tortuous ureter with severe blunting of the calyx. Why do we care here? Because the treatment options can vary depending on the grade. So 30 to 40% of antenatal hydronephrosis could be related to vesicoureteral reflux. The way they present to us, either they were found to have antenatal hydronephrosis, or if they present later in life with recurrent febrile urinary tract infections. Because the reflux itself is a benign disease, but especially in girls, if they start getting to recurrent febrile UTIs, we do ultrasound. If we see any minimal hydro, we have to do voiding cystogram, and in that condition, we might find vesicoureteral reflux. That can be the cause of recurrent pyelonephritis, because you have an open highway between the kidney and the bladder, and girls are more prone to cystitis. Whenever they get a UTI, it goes to the kidney straight, and that makes them sick with flank pain, fever, nausea, vomiting, and systemic symptoms, not like just the regular cystitis with dysuria and suprapubic pain. This can be familiar in 30% of the conditions. We only need ultrasound and voiding cystogram. Some believe in doing a DMSA, which is a nuclear scan to assess, because in a high-grade reflux like grade 5, they might have dysplastic kidney, and the kidney might be poor functioning. And that helps them with the prognosis and also with the counseling of the parents. So type of reflux, we divide it into primary and secondary. Primary, it means there is no secondary cause to it, which basically something you're born with. Secondary reflux is the reflux that happen in posterior urethral valve or neurogenic bladder, and basically telling you that there is high pressure in the bladder that blow off the valve and cause reflux, which means in the treatment, you don't have to treat the reflux, you have to treat the primary disease, which basically either it's neurogenic bladder or obstruction in the urethra. So going back to anatomy, the ureter comes, travels through the bladder wall in the muscle itself, then opens at the ureteric orifice. This intramural ureter create the valve mechanism here, so there is no actual valve that open and close. The bladder in the filling state, if you're sitting in class, the bladder wall is not contracted, the urine will be coming down all the way down. If you're in the washroom and voiding, this muscle contracts and that close the valve, so there will be no urine coming from up and the urine will be going forward. In reflux, the ureter will come straight like this without any intramural part, and I'll show it in this slide here. So in a reflux patient, the ureter will come straight without intramural part. And why I'm saying this, because when we do surgery, which we call ureteric reimplant, we have to create that intramural ureter. And I'll go back to that in a few seconds. In a secondary reflux, you don't have to treat reflux, you have to treat the actual disease that you're dealing with. So associated anomalies, ureteropelvic junction obstruction can be associated with reflux in 5 to 25%. Duplication is also associated anomalies or bladder diverticulum. Treatment options, as I mentioned, reflux is a benign disease, so we don't need to treat except in some conditions, which I will be telling you now. Antibiotic prophylaxis is key step in management of those conditions because it helps to reduce but does not take away the risk of urinary tract infections. Then when do we treat reflux? In boys or girls less than 6 years of age, if there is no urinary tract infections, we don't need to treat reflux. Girls reach age of 6 and still they have reflux, even if they have no UTIs, we have to treat, because studies showed that if reflux did not resolve by 6 years of age, the chance of resolving on its own is very small. And why do we treat in girls? Because later on, when they get pregnant, they might get recurrent febrile tract infections, and that can cause premature labor and can affect the baby. Those studies came from the era of poor hygiene, difficult access to healthcare, and antibiotic were limited, and we don't have as much antibiotics we know now. Even though classic approach, girls more than 6 years of age, you have to treat reflux. But nowadays, some are advocating not to treat reflux in girls if it's low grade, like grade 1 or 2. Even though for exam purpose for our trainees, we tell them, girl more than 6 years of age, we have to treat reflux. Boys, if they have no UTIs, we don't have to treat reflux because the chance of UTIs is less in boys. Then that takes us again for what are the other indications? Other indications, as I mentioned earlier, is febrile UTIs in boys and girls. So if you have a patient who has febrile UTIs, we put them in antibiotic prophylaxis. Question comes from the mothers always, for how long we'll keep them in antibiotic prophylaxis? Classic answer is till age of toilet training. And now there is a new school that also say at 1 year of age you can stop it. And also there is new school say if they never had UTIs, you can just keep them off antibiotic prophylaxis. And whenever they start having UTIs, you treat the UTI and put them in antibiotic prophylaxis. The classic answer is we put them in antibiotic prophylaxis till age of toilet training, and then we stop it. And if they have no UTIs, we don't treat reflux unless they're a girl and they reach age of 6. Surgical treatment here, we have two options. One is endoscopic minimal invasive, and second is ureteric reimplantation. So as I mentioned earlier, spontaneous resolution is common, especially for low-grade reflux, and that help you with the parents' counseling. For high-grade reflux, like grade 5, the chance of resolution is less than 50% or even less. Extended use of antibiotic prophylaxis is benign and safe because this is always a question from the mothers. Success rate of surgical correction is very high, especially for ureteric reimplantation. Behavioral therapy, especially for kids who are toilet trained, it means if you have someone who's toilet trained but their voiding habits are not good, especially for girls who are infrequent voiders, poor fluid intake and constipation, you have to treat that before you treat the reflux. Because if you do the best ureteric reimplant or even bulking agent injection and they're holding the urine for too long, that can affect the success rate of surgery, and this is take us somewhere between primary and secondary vesicoureteral reflux. So we always put them in antibiotic prophylaxis, making sure they do time voiding, double voiding, and we treat constipation and make sure they have enough fluid intake, because that can affect the result of surgery. Medication, in the first 2 months of life, we use amoxicillin as prophylaxis. Then after 2 months of age, we use Bactrim, which is trimethoprim and sulfonamides, because in the first 2 months of life, the liver is not mature enough and we want to make sure that this baby does not get the side effect of the sulfa, which can cause carnuncture for those babies if we use it in the first 2 months of life. Nitrofurantoin is another treatment prophylactic option of choice, but we usually like to use Bactrim, and we always base it on the culture of this patient having recurrent febrile UTI and they're on Bactrim. We always check the sensitivity, and if they're sensitive to nitro, we switch them to the nitrofurantoin prophylaxis. Surgical management, as I mentioned, indication is recurrent febrile UTI. If they're failing medical treatment with antibiotic prophylaxis, if they're not compliant, or if they have severe reflux and recurrent febrile UTI, if you have a girl who's more than 6 years of age with persistent reflux. The treatment options, first option is bulking agent injection, which we inject material called hyaluronic acid, and the generic name is hyaluronic acid, and the market name is Deflux or Dixil. This is the name of the material that we use. And basically you go with a scope and inject bulking agent to help narrowing the ureter. This works better for grade 1, 2, 3 with a success rate of grade 1, 80%, grade 2, 70%, grade 3, 60 to 70%, grade 4 is 50 to 60, grade 5 less than 50%. And some surgeons will not even use it for high grade reflux. We divide reflux, grade 1 and 2 is basically low grade, grade 3 is intermediate, and grade 4 and 5 high grade. For high grade reflux, ureteric implantation has a better result. And we usually, when we do injection for low grade reflux, we try to do it once, then we repeat the VCUG 3 months post. And if they have persistent reflux, we try to inject again. If that does not work, we don't inject the third time, and we go to the ureteric reimplantation. Ureteric reimplant, there is different techniques that we use, and the commonest technique is called Cohen technique. And as you can see in the picture here, the ureter was here, so they basically open the bladder, make an incision around the ureter and deliver it out, make a new hiatus, deliver the ureter, as you can see, tunnel it between the mucosa and the muscle to create the intramural part. And as you can see here, now we created the intramural part, and now we mature the ureter to the mucosa of the bladder again. And this is basically what we call ureteric reimplantation. There is another technique which we can do from outside of the bladder, which we call Lech-Gregoire technique, where you create tunnel in the muscle till you reach the mucosa on the outside, then tuck the ureter in and close the muscle on top of it. And that works better for unilateral reflux, and we tend not to do it for bilateral reflux because it can cause retention, and that can be permanent if we injure the nerves that travel on the lateral wall of the bladder. Last thing we'll talk about before we move to neurogenic bladder. So this is a baby who was found to have antenatal hydronephrosis. Postnatal ultrasound showed this picture here. As you can see, this is the normal kidney, and in the other kidney there is multiple cysts, multiple large, small, medium-sized cysts. And this is a closer look for that kidney. As you can see, there is multiple variable-sized cysts with no central dilation. So this is another picture for the same patient. So you can see small, medium, large cysts with no central dilation. And this is what we call multicystic dysplastic kidney. This can be fused as a tumor. So if we see this picture here of multiple variable-sized cysts with no central dilation, which means in the renal pelvis, this is not hydronephrosis. This is classic appearance of multicystic dysplastic kidney. And to confirm that, we do DMSA scan, which is a nuclear scan, and that shows no uptake by that kidney. And this is classic for multicystic dysplastic kidney. You see, there is too many questions. I don't know about the moderator. Should we take them at the end, or should we stop between the two presentations?
We'll take all the questions at the end, doctor.
Okay, sounds good. So as you can see here, there's no uptake, and this is very classic to what we call multicystic dysplastic kidney. This is a picture for pathology. So it's the most common type of cystic renal mass. This is a common MCQ question for our trainees. Common cause of abdominal mass in neonates, second to hydronephrosis, and it can be associated with contralateral anomalies, mainly vesicoureteral reflux on the other side, or they can have ureteropelvic junction obstruction. That's mean if we see hydro on the other side, we have to do VCUG to rule out reflux. So how do we differentiate this from hydronephrosis? There is 3 differentiated factors here. 1, no communication between those cysts. I think the picture I showed you earlier here shows that very well. So you can see there is multiple cysts that does not communicate, and there is no central dilation, because if there is hydro, it will be grade 4 hydro, and you'll see pelvic dilation. And also you lose the reniform shape of the kidney, and also there is no uptake in the nuclear scan. These are the the 4 features that help us to differentiate. We usually, when we see this ultrasound, very classic, and we can tell this is multicystic plastic, and we can do a nuclear scan to confirm it. But at least for you guys, we have to make sure, this is the most common type of cystic renal disease, and also it's the second commonest cause of palpable kidney in those babies after hydronephrosis. This picture showing you, this is a patient with severe hydro, and you can see there is central dilation, and the kidney still has its own shape. And if we do nuclear scan, we'll see uptake. But in this one, no central dilation, and you can see the kidney looks very irregular. And if you do nuclear scan, there will be no uptake. So how we diagnose it, we talked about that, and we always do VCUG to rule out contralateral reflux and treat reflux on that side, because if we leave reflux with recurrent febrile UTI, that patient has a single functioning kidney, and we want to protect that kidney. And some even advocate, they have asymptomatic VUR, they want to treat surgically, because they said, why do we wait for urinary tract infections or febrile UTIs? We want to protect that kidney. So multicystic plastic kidney, usually with time, that kidney gets smaller and smaller and atrophy and disappear. So when we counsel those parents, we tell them you have to follow up, and we usually do follow up with ultrasound every 6 months. With time, usually 2 to 5 years of age, that kidney disappear completely. Then there is a question of Wilms tumor in those kidneys. Previously, they thought there is an association between them, and actually there is, but we have to do 2,000 nephrectomy to prevent one Wilms tumor, which means if we follow this patient regularly and make sure there is no increase in the size and no masses in that kidney, and if we diagnose those kidney early, if they develop Wilms, then we can protect 1,999 kids from nephrectomy. It's an invasive procedure. So indication to remove those kidneys, the multicystic plastic kidney, if it's growing in size and follow-up ultrasound, then you worry there might be something cooking, and then you remove one. Or if the mass size increase and also compress the lungs or even the stomach or the neighbor organs, then you have to remove it. If they get recurrent hematuria, recurrent pyelonephritis, then you have to remove that kidney, and usually we do this laparoscopically. But I can't remember any of the cases of multicystic plastic kidney that I ended up removing, just because usually they're asymptomatic, but these are the indications to remove those kidneys. Duplex anomaly is one of the other differential diagnoses of babies with antenatal hydronephrosis, and it's a very complicated topic, which means يدخل معاها reflux, يدخل معاها obstruction, but I will talk just very high level, so at least you're aware. Duplication is a common anomaly that we see. It can be complete or incomplete, which means you can see 2 parts of the kidney with 2 ureters that join together, either high, but then it's 1 ureter, or they can join the middle, or they can have full complete duplication. Why do we care about duplication? Because you can see reflux, you can see ureteropelvic junction obstruction, you can see ureterocele with duplication anomalies. So this is a complete duplication. As you can see, there is upper moiety, lower moiety, and 2 ureters going all the way down. Usually, if there is associated anomalies, usually the upper pole moiety usually is poor functioning. In some conditions, normal, but if you have anomalies, and usually if you have ureterocele, it happens in the upper pole moiety, and there is obstruction, which make the kidney in the development phase under pressure and can affect the function of the upper pole. And some of these kidneys are born with non-functioning upper moiety. There is something we call Weger-Meyer rule, which basically, if you have a full duplication of the kidney, the lower moiety يكون فيها reflux, والupper moiety يكون فيها obstruction, and usually associated with either ureterocele or ectopic ureter. We do ultrasound postnatally, and if we're concerned about duplication, we do VCUG to rule out reflux, and we do DMSA to assess the upper pole function. And if there is no hydro, we don't need to do any of this. We only do ultrasound, and if it shows there is a duplication with no hydro, we don't need to do any of this investigation, and we don't need to put them in antibiotic prophylaxis. As I mentioned earlier, the upper pole moiety can be associated with the ureterocele. As you can see, ureterocele is basically the distal part of the ureter is dilated, while opening of the ureter is very small, like a nipple. And that causes obstruction and can cause back pressure, and also can decrease function, or even they lose function of the upper moiety. So what do we do? If there is a good function of that moiety, we go with the cystoscope and incise that ureterocele. This is an option. If there is poor functioning of the kidney and there is recurrent infection, we remove that moiety completely all the way down. So duplication anomaly with ureterocele commoner in males than females. In females more than males. And what do we do to treat? If there is reflux in the lower moiety, we treat it like a primary reflux. So we put them in antibiotic prophylaxis, and we stop it at the age of toilet training. If there is obstruction and worsening hydro of the upper pole, we can either incise the ureterocele, or the other option is we can remove all this piece and do ureteric reimplantation, which can be done only for that moiety, or if there is reflux in the other moiety, we do what we call common sheath reimplant, where you reimplant both ureters together because they share the same blood supply. I'm not going to get into too much details because it will be confusing for you guys, but at least just to, a duplication anomaly can be associated with upper pole dilation, which can be related to ureterocele. Lower pole can have reflux, even though this is not a straight, just 100% role, because you can have reflux in the upper moiety too, but this is how it's common as common. So as I mentioned, endoscopic treatment is we go with the cystoscope and we incise ureterocele. Some of these babies are born with severe hydronephrosis and they can get septic, and in that condition you just go with the cystoscope and drain, just make an incision in that ureterocele to drain it, and usually you might see pus coming out. Differential diagnosis. That ureterocele can extend between the labias, because you guys might see similar representation in pediatric surgery. So intralabial mass is something that you might be called to see. And one of the differential diagnoses here is ectopic ureterocele or prolapsing ureterocele. As you can see here, there is something bulging between the labias, and that can be this part of the ureter bulging all the way between the labia. The other differential diagnosis you have to be aware of can be sarcoma, can be urethral prolapse, can be imperforated hymen, can be Gardner duct cyst, or can be vaginal inclusion cyst. So you have to be familiar. And if this patient comes in septic and you do ultrasound, you find severe hydro in the upper pole. This is classic for ureterocele. And in the bedside, you make a small incision and you place a Foley catheter till this baby sepsis improves. Then you go on later on to treat the ureterocele. So you might see this presentation and you have to be familiar with it. The voiding cystogram for the same patient, showing you this is called the cobra head sign, which is basically the ureterocele causing a filling defect. And you can see there is reflux in the lower moiety, as I mentioned, in the duplication anomaly. Ultrasound for the same patient I showed you earlier, showing upper pole cyst, which going with no parenchyma, probably no function, and the ureter will be dilated all the way down. And this is classic for upper moiety ureterocele with non-functioning upper moiety. The fact there is a clear difference between these two conditions, I think I'll stop here to take questions. Then later on, I'll discuss neurogenic bladder just to avoid confusion and overlap between these two conditions. So I'll start going through the questions.
Okay,
if you don't mind, the moderator, I will divide it into two parts, if that's okay.
Oh, okay, sure, doctor. So we have a question about what is the best time to do postnatal ultrasound in neonate with prenatal hydronephrosis?
So best time, usually, we try to avoid doing it in the first 24 hours because they get dehydrated and we might not see what we want to see in terms of hydro. Even though if you have someone with writing in the wall, it's clear عنده oligohydramnia في pregnancy, bilateral hydro, bladder is distended في كل scans. So this can be posterior valve. So in this condition, I would place the catheter, stabilize the baby, do ultrasound as soon as you can, usually in the first 24 hours. Ideally, the best time, بعد the first 24 hours to avoid dehydration in the first 24 hours can affect, and might not give you the picture you want. Ideally, you should repeat it for the second day. If it's unilateral hydro, you would do it postnatally and repeat it at 1 month of age. If it's bilateral hydro, you do ultrasound postnatally. If it shows bilateral hydro, then you do voiding cystogram as soon as you can if the baby is stable. If the baby is not stable, لأن بعضهم يكونوا intubated small for their age. As long as you have a catheter in place with creatinine trending down, the urine output كويس, you can wait till he stabilizes and do the voiding cystogram.
Okay, great. Thank you. Another question, if a family bring their child with a recurrent history of UTI with no previous investigations, will you start with ultrasound or avoiding cystourethrogram?
Always ultrasound. But this takes us to what if the ultrasound is normal? Do we roll out VUR? لا, مو شرط. But the thing that when we do ultrasound, if you work in a place where they know how to do ultrasound, البلادر is a hollow organ زي الجول bladder. if the bladder is not full, then you will not see anomalies inside it ولا حتشوف reflux في upper pole. So that's why we always ask radiologists to do it with a full bladder, because if there is reflux, you will see dilation in the upper pole. When they void and empty, reflux, the bladder empties, then you might see resolution of the hydro. So if you see hydro that goes back and forth in follow-up for some of your patients, that can trigger the idea of V1. So if you have someone with recurrent febrile UTI, you do ultrasound first. Then if you don't have hydro and those febrile UTI continues, you have to do VCUG even if there's no hydro.
Clear.
What's the age which we can do MAC3? Ideally, we do it at 1 month of age, because the first month of age, the kidney is not mature enough and it might not give you the result you want. And as I mentioned, usually it's not urgent to do pyeloplasty حتى لو فيه UBG obstruction the first month of life, unless the hydro is very severe or bilateral hydro and you're worried about the kidneys. Ideally, we do it at 1 month of age.
Okay, great. When do you use the MAC3 and when to do the DTPA?
Depend on what's available in your institution. Both give you the same answer.
Do you always incise at 12 o'clock position? I think they mean the posterior urethral valve.
Yes, so the question, ideally 5-7, 12 is optional. When you go with the cystoscope, if you see when you avulse the membrane, will incise it. Some believe in the 5 and 7 are enough. Others believe in no, they do always 5, 7, 12. Some are in between. You go to the shift issue in the middle that still might obstruct his urine flow. I will incise. For myself, I always incise. Unless if it's clear. احيانا الفالف له 4 انواع. الكلاسيك 1 is type 3 اللي شكله زي الفورك. يكون 2 leaflets that meet in the midline بعدين extend down. Always for in that one 5 and 7 are must. 12 is optional, depending if when you avulse those and membrane flattened, it's enough. If you still see it, you have to incise. Others believe انه هذول الكيدز احيانا البلادر نيك تصير عندهم high, يسمونه high bladder neck. Others believes انه they have always to have incised the bladder neck to make the urine flow smooth, which will be I think this is the extreme. But 5 and 7 is must, 12 is optional.
Okay, great. What is the difference between polycystic kidney disease and multidysplastic kidney disease?
والله يعني it's a clear difference. يعني I think polycystic disease, we're talking about different disease. Polycystic kidney disease يكون عندك cyst في both kidneys, في liver, في pancreas. يعني you're talking about totally different disease. It's one if you're differential, but for multicystic ما يكون عندك cyst إلا في one kidney والother kidney is normal وما في cyst في other organs وما في associated anomalies. I think we're talking about totally different disease. If we know what's polycystic disease, يعني I mean لكن في long differential for cyst in the kidney. يعني it can be cystic renal cell carcinoma, it can be cystic worms, it can be multicystic nephroma. يعني differential يطول. لكن we have to be شوية realistic when we prioritize differential. يعني I think polycystic is one of the differential, but it has to be low on your list.
Yeah, thank you. How frequently we follow up patient with multicystic kidney disease in OPD?
I usually follow them every 6 months with ultrasound.
6 months, thank you. At what age is nuclear scan can be done?
I think السؤال هذا واللي بعده جاوبناه at 1 month of age. And in follow-up, يعني if we do it, let's say عندنا unilateral hydro and we did nuclear scan, we showed no obstruction and good drainage. If in the follow-up, the hydro gets worse, then you have to reset your clock. So you think this could be a partial obstruction, which we call partial ureteropelvic junction obstruction. In that condition, if there is worsening hydro, you have to repeat it. And in that case, and it can be repeated in 6 months or 1 year from the previous one if you see worsening hydro.
Thank you. What is the approach for prolapsing urethroceles?
Good question. I think I have a slide for that. Basically, prolapsing urethroceles, you would reduce it in the bedside if you can, basically just by pushing it with your hand. If it does not reduce, or if you cannot place the catheter because it's obscuring your vision, because you have to place a catheter to drain the bladder, then you would aspirate it with a syringe. تدخل بسرنج فيها cannula, تدخل بالneedle. You pull back your needle and keep the cannula in. And if this kid is septic, you'll see pus coming out. You can incise it with a scalpel on the bedside too, and these are temporary measures at least to get the baby stable, and later on you have to treat it. If you cannot do any of that, then you have to take him to the OR, incise it, do cystoscopy, do whatever it needs till he's stable. Later on, then we have to do excision of that urethrocele and do ureteric reimplantation.
Okay, good. Ectopic versus intravesical urethroceles, how they differ in presentation and management?
طبعا ectopic ureter is a different condition. Ectopic ureter بس احيانا يتداخلون. ectopic ureter, اليوريتر can go في البويز commonest يعني can go to different location. في البويز احيانا يكون في البلادر نيك، كان بي في السيمينال فيزيكال، في الباز ديفرنس، احيانا في البلادر نيك، احيانا في ايفن في الريكتم. الريكتم is different, it's a fistula، بس قصدي انه usually goes to the Wolffian duct structures. الجيرلز commonest location في البلادر نيك، وعادة يكون presentation حقهم urine incontinence, which means احيانا يجونك girls who fail to be toilet trained، وبعدين تسوي لهم ultrasound تلقى عندهم hydro, it looks like duplex، وتسوي VCUG تلقى ممكن في reflux ممكن ما في. You have someone who has never been dry at all. في picture of duplication في الالتراساوند عاده نشوف زي الريدج اوف تيشو between the upper and lower moiety نسوي لهم MRI والام ار يو. الام ار يو يوريك اذا في ectopic urethra في البلادر نيك ولا في الفاجينا. If you have someone who's always wet day and night that never be dry fail to be toilet trained, you have to keep in mind ectopic urethra. بالنسبه لليوريتروسيل في انواع، في شيء في البلادر، في شيء في البلادر نيك، في شيء يطلع برا يعني يسمونه سيكو يوريتروسيل. والمانجمنت is the same except you have to make sure انه are you dealing with duplication anomaly ولا هذا single system، لانه you can see urethroceles في single system. ليش؟ لانه اذا معه في نفس الوقت VUR then الكلاسيك approach انك تسوي common sheath reimplant where you reimplant both ureter، منها انك تشيل اليوريتروسيل ومنها انك treat الريفلكس. اذا في only urethroceles then you might incise urethroceles بالcystoscopy only، knowing انه احيانا incising urethroceles ممكن يسبب لك reflux. That's why when we incise it في most dependent area في 5 o'clock او 6 o'clock عشان ما يكون عندك secondary reflux. Even though 15 to 40% post urethroceles incision with cystoscopy يجيهم reflux post incision، عشان كذا لازم تسوي VCUG post. فاليوريتروسيل نفس الشيء يعني I think if you don't see it and treat it often, I don't think you should treat it لأنه it can be associated with other associated anomalies, but at least you know a common approach.
Okay, great. We'll take only one more question and then we can continue the lecture. If ultrasound showed absent kidney in one side and hydrourethronephrosis in the other side, do we start with VCUG or MAC3?
Always VCUG because you might be missing posterior valve, and this is single functioning kidney, and we don't want to miss diagnosis with posterior valve. Why I'm saying this? Because if you miss a diagnosis of posterior valve in a patient with unilateral or bilateral, يعني عنده both kidneys ولا one kidney, this patient might have lifelong renal impairment, might go in renal failure, so you don't want to miss that. Especially now you're dealing with a single kidney, so this is very valuable organ, and you don't want to miss that diagnosis. If you do VCUG and it's normal, then you can do a MAC3.
Thank you. We have still a couple of questions, but we'll go through the presentation first, and after that
one question is important. Luckily we live in a culture where circumcision is it's a habit, it's a religious thing. In other cultures, mainly in Western country, circumcision is done عادة للJewish people who believes in it. So some ask if circumcision is a must. Yes, it is. It reduces the chance of UTI significantly. So the first thing we do for babies with reflux or even posterior valve, we tell them that they have to do circumcision as soon as they can because it reduces the chance of UTIs significantly. Move back to the presentation. Neurogenic bladder is one of the common thing we see as pediatric urologists, and sometimes can be associated with other anomalies like Vesicoureteral anomalies, and you guys see some of these children. So there's common etiologies of neurogenic bladder, and spina bifida are different types, and the commonest is the classic spina bifida, but you can have a patient with spina bifida occulta, which is basically patient you might not see any signs on the outside, but they might have spina bifida. Spinal cord tethering, which I'll talk about shortly. Sacral agenesis, and this is a patient who missing all the sacral bones, and that can also affect the last part of the spinal cord, which can affect the bladder or bowel. And I think we share those patients in those conditions because they cannot void normally and they cannot defecate normally. And I will not be talking about spinal cord injuries here or spinal cord lesion. We'll be only talking about spina bifida specific. Bowel bladder syndrome is something similar to what we'll be talking about in a patient with spina bifida because it's basically that bladder developing high pressure and it shares exactly the same features and you have to treat it similarly. So spina bifida happens in 1 in 8,000 when we realize that it's common in a patient who's not taking folic acid in the pregnancy, that reduced significantly by 50% with folic acid intake in the pregnancy. It can run in families in 2 to 5%. Commonest spina bifida level is lumbosacral spine in 47% of the time, but it can happen in the cervical, thoracic, lumbar, or sacral, but the commonest is lumbosacral. When we examine the baby in the outside, we always check their back. So always, please, when you examine babies, check the back because you might be the only one who picks this up because it might get missed by too many physicians. So always look at the back and look for any hair tuft, any dimples in the back, any asymmetry in the buttocks muscle, or if there is any one elevated more than the other one. If you see any bulge, this can be diagnostic for spina bifida. So why do we care about spina bifida in urology? Because that can affect the nerves that control the bladder and the rectum and defecation and urination, and they share the same nerve roots. So spina bifida, when it causes neurogenic bladder, this disease can be very variable, which means it's either you can have a very flaccid bladder that cannot contract at all, or you can have the very tense bladder that's very high pressure bladder, or you can have something in between. It also can affect the sphincter itself. So normally when we look at the parasympathetic system that controls the urination, ideally when you contract your bladder, you relax your sphincter so the urine comes out. Some of these patients have dyssynergia, so basically they contract the bladder and contract the sphincter, and that can cause very high pressure in the bladder, which can affect the kidneys and the upper tract. So spinal level is not predictive, which means for spinal cord injury, we know that if you have spinal cord injury at C6 or C5 or L5, الموتر والsensory effect هو 1 2 3 4. Spina bifida is different. That means if it's L4 L5, you cannot predict the effect على البلادر ولا على الcolon, which means it can be variable. This is 1. 2, it can change with time. وهذه أهم نقطة. This is the most important part. You have to make sure your patient realize, which means this patient was fine in the beginning and they were following with you for a year or 2, then they disappear and they thought things are okay. Things can change with time, which means the bladder or colon can go from one state to another. Specifically bladder is basically الهوم حق الكدنيز, which means something can change quickly and dramatically if they don't. It's not a static disease, it's a spectrum. So you can move from one state to another without noticing that. Spina bifida, there is different types of spina bifida. There is meningocele, dependent. Is it just the covering of the spinal cord? Is it the spinal cord bulging? Is it the meninges? Is it just the sac? هل في lipoma around it? There is different types, and our colleagues in neurosurgery deals with this as soon as the baby is born, and also they can do it in antenatally, which is one of the commonest use of antenatal intervention. The second antenatal intervention that we see as a urologist sometimes, which is still investigational, the kids اللي عندهم posterior valve, we diagnose it early. Sometimes they place a shunt, which helped to reduce the pressure in the bladder, even though a study showed it was not too protective for the kidneys. And sometimes they would inject amniotic fluid to protect the kidney, to protect the baby from the compression in the face and legs and limbs. Even though the antenatal intervention for valve patient is still investigation and it did not proven to be very effective, even though it's still promising, but it's still evolving. But for neurogenic bladder, it showed it can protect or reduce the effect on the kidneys if you do the spinal cord surgery early, even though it's very advanced and it's done at very specific centers in the world. Our goal of treatment of neurogenic bladder, which is the first thing I always discuss with the parents, why do we care? Why it's important that they follow up? Priority here are 3. 1, protect the kidneys, واللي هي basically renal function. 2nd, achieve continence, basically because you want them to get off the diaper. So we have to make sure they can control the urine, or if they cannot, they have to do intermittent catheterization, so at least we can get rid of the catheter. The 3rd thing, prevent the complication. Complication هنا هي UTIs, stones, they cannot get off diaper, social or psychological impact عليهم من الcondition. The most important thing we direct our treatment to هو number 1 اللي to protect the upper tract والkidney. So we take history. Was the pregnancy okay? When they diagnosed spina bifida, have they seen hydro? Was this fixed antenatally or postnatally? Then we check the ultrasound postnatally, looking for ultrasound, and if there is any hydro, we check the baseline creatinine. Then we always recommend to do baseline urodynamic study, which means you want to know how was the bladder whenever the baby is born. And ideally, this is done post repair, and repair takes priority because they don't want to leave the spinal cord outside and cause meningitis and things like that. So ideally, when this patient have a repair, we wait for 3 months because the spinal cord go into spinal shock, which means edema or inflammation in the area might affect the result of the urodynamic study and might not give us the actual status of the bladder. Next, I'll be talking about what's urodynamic study, just briefly. Urodynamic study, where you place a catheter in the urethra all the way to the bladder ويكون فيها sensor. Another catheter in the rectum, and the catheter rectum that helps you to measure the intra-abdominal pressure. Why do we place this? Because we want to know the vesical pressure, البريشر حق البلادر wall. So we subtract the intravesical pressure من intra-abdominal pressure, وهذا يعطينا detrusor pressure. وهو one of the things that we care about في urodynamic study. So basically we subtract the intra-abdominal pressure من الانترافازايكال pressure هذا يعطينا الديتروزال pressure. And what do we do in this study? We fill the bladder with saline with the fluid of choice to know the capacity, how big is the bladder, also to know هل في overactive bladder contraction which is common for neurogenic bladder, and also the bladder wall زي البالونة المفروض when the bladder fills it stretches with you. And in neurogenic bladder you can have a stiff bladder which we call poor compliance bladder. And these are the three things that we measure in neurogenic bladder. So as you can see here, we want to see first, how much is the capacity, how good is the compliance and the elasticity of the bladder, and how good is the sphincter, is it tight at the time of voiding, هل في fulfilling phase when he's not voiding, هل في contractions في البلادر. These are the things that we use. The non-invasive urodynamic study بدون هذه without catheters, where you get the patient to void in a toilet, and في زي meter here where it measures how good is the flow of the urine. This is just for a patient if you're thinking of obstruction, to show how good is the flow and if there is any sphincter contraction مع voiding. So this one, it shows you this patient voided 400 ml. It can measure how much is residual, how good is the contraction, or any AMG activity which tells you if there is sphincter activity. بس هذه عادة done patients اللي you think إن عندهم obstruction مو neurogenic bladder. Neurogenic bladder, this is how the urodynamic study, and I don't expect you how to read it, but at least to know why we do it. So basically, هنا we're filling the bladder with fluid. As you can see, his capacity reached to almost 400. So his bladder capacity here is 400. And there is a formula that helps you to know the bladder capacity, which usually for the first year of age, 7 multiplied by weight. يعني إذا وزنه 7, it's 49. More than 1 year of age, the capacity is age plus 2 multiplied by 30. يعني إذا عمره 10 أو عمره 8, then age plus 2 is 10 multiplied by 30, so his capacity is 300. So this patient, if he's عمره 10 years, this is normal bladder capacity. With filling, if the pressure is going up زي كذا يطلع, هذا means it's poor compliant in the bladder ما عندها elasticity. Also we check for contraction. عادة المفروض يكون flat في الفيلنج. إذا شفت jump هنا without increase في intra-abdominal pressure, هذا يدل لك إنه فيه overactivity. I'll show you now. This is a patient with detrusor overactivity. عنده contraction هنا وما في معها abdominal, mainly في البلادر. شايفين هنا في الفيزيكال وفي الديتروزر. هذه detrusor overactivity, multiple contraction with filling, which ended with voiding. ما قدر يمسكها and he leaked. This is a patient with poor compliance with filling. نعبي والpressure قاعد يطلع معنا. This is what we call poor compliance. Why do we care about these? Because first, we need to know the baseline. Second, to help us to predict the prognosis, because if the pressure inside the bladder more than specific number, it tells you an upper tract higher risk of renal impairment. Also, it tells you how aggressive you should be with your treatment, and also to help you what's the best treatment approach. And we'll talk about this in the next few slides. Yes.
Sorry to interrupt you, but we have only remaining 10 minutes for the
Yeah, it will be enough. Poor compliant bladder, يكون the pressure for bladder for filling phase more than 40. That tells us that we have to be aggressive in treatment and to prevent the upper tract changes. The main treatment options here is intermittent catheterization or anticholinergic medication, even though this is not for all patients. Spinal cord tethering, just in brief, يكون child is normal, 100% normal, suddenly he starts to be incontinent. Secondary to tethering in the cord, يكون عنده spina bifida occulta with a growth spurt. It caused tension in the cord. Now he's incontinent for urine and stool. Suddenly he starts losing sensation for lower limbs, and our colleagues in neurosurgery does the release of the cord tethering on an urgent basis. Follow-up for spina bifida, we usually see them 3 months post repair, then 6 monthly after with ultrasound and creatinine, urodynamic yearly, and if there is any change in their status, we have to change the management, and I will talk about the management depending on what state. Neurogenic bladder, we divide it into, is it issue with storing the urine, is it issue with the bladder sphincter when we talk about storing, and is it issue with emptying, and I will show you what that means. إذا عندنا مريض عنده issue and the bladder is overactive, which means multiple contractions happens and we want to lower those contractions, and also he's having hard time emptying. So we put him in antibiotic, prophylaxis, we put them in intermittent catheterization and anticholinergic. Anticholinergic help to increase the capacity of the bladder and also decrease the overactive bladder contraction. Other option is Botox injection. If we impart into Botox, we have to add to it intermittent catheterization because it paralyzes the bladder, and we never start a patient in Botox without them يعني لازم نتأكد انهم compliant at CIC, otherwise we should not put them in. Plus it's the second line, it's not the first line. If we have someone who's in this for a while and you want to try something different, you can try Botox. Later on, augmentation is an option which can be done with metronidazole, and I will talk about that. If the issue with the sphincter, في ناس عندهم يكون sphincter very loose and they keep leaking, and in that condition you put them in alpha agonist, نفس الميديكيشن اللي موجوده في الكولد اللي هو pseudoephedrine, تساعد انه contract the pelvic muscle even though it doesn't work well. You can use bulking agent or you can do bladder neck reconstruction. If the sphincter عندهم tight, which means there is dysenergy between the bladder contract and at the same time the sphincter contract, we do Botox for the sphincter and we start them an anticholinergic medication with or without Botox for the bladder. If the bladder is small or this patient failing all medical treatment, we move to the bladder augmentation. الهدف من bladder augmentation إنه you increase the bladder capacity, which means the compliance بتزيد, which means also the upper tract pressure will decrease, the reflux will decrease, and we increase the size of the khazan. We use a piece of the ileal piece, usually 15 centimeter away from the ileocecal junction, total length of 20 centimeter. We tubularize it into a U shape where we open one side and make it a U shape. Then we reconfigure it as a U, put it in the top of the bladder where we open the bladder anterior wall زي V, ونحطها on top and we close it. Always we keep a mesentery and make sure we have a good mesentery with it. With that, always to make the catheterization easy, especially إذا أنت سويت bladder neck reconstruction to avoid leak from below. ناخذ appendix with its own mesentery and connect it to the bladder wall and bring it to the umbilicus so they can catheterize through the umbilicus to make it easier for the family. If you have somebody with a hydronephrotic non-functioning kidney, it's an option to use the ureter here to augment the bladder without electrolyte imbalance اللي تصير مع using of the ileum to augment the bladder. Something to keep in mind, if you use ileum, you might get hypochloremic metabolic acidosis. So you have to make sure you do. Usually our colleagues in nephrology follow that, and if we see it, we send them to nephrology to correct it. Why would that happen? Because ammonium gets reabsorbed with the bladder mucosa and can cause chronic acidosis. And if you have someone with borderline renal impairment, this can put them from stage 4 CKD to stage 3 to stage 4 or even worse. So if you do this in a patient with a borderline renal impairment, you have to tell them this is a possibility. They might get acidotic more and renal impairment get worse. And that's why we always try to time it well before transplant. And ideally, it should be done 6 months before transplant, at least to prepare the environment for the new kidney, to lower the pressure for the new kidney. So we usually do metronidazole and augmentation 6 months before transplant. This is it, and I'm happy to answer any questions.
Thank you so much, Dr. Fahad, for this great, amazingly covered informative lecture. We will wait for the questions of the audience. We have 5 more minutes. If you have any questions, you can post it here.
While we're waiting for the questions, just to mention, a neurogenic bladder it's not a one disease, it's a spectrum. You have to tailor your management depending on what stage. يعني أحيانا يجونا مرضى bladder كانت overactive, but then they move to atonic bladder or hypotonic bladder, they move to atonic. So you have to monitor this. And also this was a lifelong issue. That means those patients will need to follow up with us for the rest of their life. So usually they follow with us till age 15, 16, or sometimes even we see patients with 21 years of age because we face resistance from our colleagues in adult urology to accept them. And luckily now we start getting people specializing in functional neurology or neurourology bladder and see these patients. It's a disease that's moved with the patient for the rest of their life, and you have to make sure you cover all the aspects.
So I guess no questions. We have only one question from the first part. There's a question. When bladder neck closure is indicated?
Bladder neck closure is to me an old approach. A new generation now, we tend not to do bladder neck closure because sometimes we need to, especially in females or girls, because sometimes it's a short urethra and bladder neck and they might leak. So we tend to do bladder neck reconstruction to give them a backup mechanism. If they lose their metronidazole and closes, if you close the bladder neck, then خلاص you're cooked. You might need to do suprapubic. وأحيانا if you're in emergency in the bedside ما تدري وين الميزنتري جاية حقت الباول, so you might injure it. So we try to do it. So having a bladder neck there, it's a backup mechanism. Even though in some condition they continue leaking and we go back again and close it, but we tend not to start with it, even though it's an option.
Okay, great. Thank you. What is the approach for management of urinary incontinence in children?
It's a very big topic يعني we're talking هنا about avoiding dysfunction وهذا التريتمنت حقه behavioral therapy with time voiding double voiding anticholinergic ممكن يكون ectopic ureter ممكن يكون neurogenic bladder ممكن يكون non-neurogenic bladder which we call Hinman syndrome يعني very big topic ما صراحة I don't know how to answer this question but if there is a specific question I'm happy to answer it.
Management of valve bladder syndrome.
It's exactly نفس اللي نسويه في neurogenic bladder. It's a disease that changed from hypertonic to hypotonic to atonic bladder. So you target it الهدف to protect the kidney. So الكلاسيك approach الناس اللي عندهم posterior valve الغالب بس follow up عادي وتمام. اللي عندهم neurogenic bladder secondary to valve نسميهم valve bladder. Then you treat them نفس الشيء. CIC or anticholinergic, possible botox, possible augmentation, possible reimplant, possible transplant, depending on what state of the disease they are. It's exactly نفس neurogenic.
Okay, we'll take only one more question. During my 3-year of residency, I have seen 2 patients with augmentation cystoplasty died of sepsis. What is the survival rate in your area and how you follow them?
I would say I've never seen sepsis from, actually I've seen one patient, not sepsis, can query bowel leak وكذا, لكن first the sepsis from augmentation doesn't happen. I would say something يعني very rare. And actually we do this on a regular basis يعني, and I work في 2 institutes في الجامعي وفي King Faisal and I've never seen sepsis or death from bladder augmentation. It's a very safe procedure, a very common procedure we do as pediatric urologists, and it always works. Survival rate, I would say, I'm telling you, death can happen from any procedure, but augmentation itself, it's a very common procedure we do, and it's very safe and very successful.
Thank you so much, Dr. Fahad. Thank you for your time. Thank you for your great effort. We have a lot of questions. Kindly post your questions in Twitter, and Dr. Fahad can answer them from there.
I'm happy to answer them. If you mention me and my Twitter account, I'm very happy to answer them. But last question هنا بس, how effective is sacral spinal nerve stimulation? Promising, it's something new, something still investigational. It's not optimum for these patients because now we've seen a case that got presented in media as an optimum care, which the cure. It's not mainly used for specific conditions for adulthood اللي عندهم non-neurogenic bladder, but for spina bifida patient with neurogenic bladder is still investigational, did not proven to be effective. شكرا لكم على الفرصة وإن شاء الله إني أفدتكم.
Thank you so much, Dr. Fahad.